Good evening, I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. I have a wonderful guest tonight. All of our guests are wonderful, as I sometimes say. This is someone who we actually invited back, so it really tells you how wonderful he is. This is Dr. Brian Gilchrist, a good friend. He's the head of pediatric surgery in many different places. And he's really a wonderful pediatric surgeon, wonderful doctor, and someone who's always, his insight has always been comforting to me through my years that we worked together at Richmond University Medical Center. So Brian, please, as a friend and as a colleague, thank you so much for coming.
My pleasure. Great to be here.
We'll talk about a little bit about pediatric surgery for people who might not have seen you on the show in the past. What's different about a pediatric surgeon? Actually, let's start from the beginning. What training does a pediatric surgeon have?
Well, pediatric surgeons in the United States only number 450. That's it. And all of us are trained in general surgery, and then we do a fellowship in pediatric surgery for 2 years. But most of us have also done extra training. For instance, I did liver, pancreas, and kidney transplantation at Harvard before. So all of us are pretty multi-tasked in our abilities to do different aspects of surgery.
What are the most common surgeries that you do, and how would someone get to a pediatric surgeon? If you think about it, pediatrics under the age of 18 in most cases, even maybe up to 21, and you have a pediatrician who most of our families bond very much with, and usually the pediatrician will give us the name of a pediatric surgeon, or if you, God forbid, have to go to the hospital for an emergency. So tell us a little bit where and how you get referrals.
So it's interesting. I mean, Staten Island is a true community, and all the pediatricians I know personally very well, and they have to trust you with their, they love these kids, and they're so bonded to the families, as you say, but they send me an awful lot of cases from all over Staten Island. So that's pretty much who the gatekeepers are. It's the pediatricians. But also the emergency room, and at Rumsey we have a brand new phenomenal emergency room, and the pediatric side of it now is manned by people from Mount Sinai. And these kids who have just started their careers are superb pediatric ER people. So I see a lot of cases from them, and common to us are, of course, appendicitis is huge, and there's a whole discussion about that, which I'll get into. Foreign bodies of the airway, torsions of the testicle.
So how do you get a foreign body of the airway?
Well, it's usually boys, it's never girls, and they're usually toddlers who are on the floor, and little boys put everything into their mouths. So all of a sudden you've got a foreign body in the airway or in the esophagus, and by definition, you've got to take it out that night. You can't let these things sit there, take an x-ray and check it the next day, get at it and get it out, because otherwise it becomes a problem. The other things that are very common for us are trauma, and Rumsey, of course, is a level 1 trauma center. So we see a fair bit of trauma, and in the summertime, from Memorial Day to Labor Day, we call that the killing fields, because kids are in pools, kids are on bicycles, kids are out and about. That's when children get injured, and that's why I never take a day off during the summer. I go away in the winter, but I never go away in the summer.
Really?
Yeah.
And tell me about the team that you have. So if you think about it, in many hospitals, I don't think all hospitals are set up for pediatric surgery.
They aren't.
A lot of hospitals transfer children, even in the New York area, but especially in the suburbs, and especially when we get to some of the rural areas.
So here's a very interesting thing. Today, we had a very important person's child come into our hospital. And the mother said, we were going to go to Cornell. And our concierge pediatrician, who I don't know, had told them to go to the city. And they end up at our place, and instead of having a bunch of residents or fellows like we all were, you get a senior pediatric surgeon, you get the chairman of pediatrics, Dr. Brian McMahon, and I there directly taking care of your kid. So not only do we have the spirit that's correct for a children's center, but I have 3 of the finest pediatric anesthesiologists I've ever known. I spent most of my career in a children's hospital. These guys are better than anybody I've ever had. And we just hired a new one. So our armamentarium for taking care of kids is just second to none right now.
And what happens after the surgery? It has to be post-operative care. And are you comfortable with the
post-operative care? Let's be honest about this now. The doctors don't take care of the patients. The nurses take care of the patients.
Absolutely.
The nurses are the most important part of the entire medical profession, frankly. And the people at Rumsey are like angels. They have that Judeo-Christian background where the milk of kindness is a part of their being, and they take incredibly good care and vigilant care of these children.
And it's true, as a neurologist, I see mostly adults, but I've had some training with pediatric neurology. Interesting enough, almost in any hospital, the pediatrics department, there's a different level of care.
Oh, for sure.
The neonatal intensive care unit, the pediatrics department, the nurses who go into pediatrics, really the saintliness, the holiness of those people are different than almost any other group that I've ever seen.
Well, it's sacred. Think about it for a second. A parent brings the most precious thing in their world to you to take care of. So if you don't see the sanctity of that and the sacredness of that, then you're in the wrong profession. And at our place, at Rumsey in particular, I've never seen such great care.
Tell me about procedures. So things have changed over the years. Appendectomies from going to a laparoscopic. I don't know if they're doing it robotically, but tell us a little bit about what in pediatrics. Because again, actually give us the global picture of general surgery, but specifically with pediatrics, how things are getting better. I just had a guest on very recently talking about head and neck surgery, and that they're not doing this radical dissection that they used to do that was so disfiguring. People couldn't swallow afterwards. It was so frightening to see as a medical student and as a resident. So where are we going to now with this?
So let me interject about head and neck for a minute. My father and grandfather were general surgeons, and my father used to do a lot of radical necks. And he used to have his patients, the radical neck patients, come to his office on a different day than his general surgical patients because nobody wanted to look at them. It was so atrocious what you did to these people. But those days are gone. Surgery in medicine, think about this for a second, how things have changed. No longer are people doing radical mastectomies. No longer are people doing many coronary bypasses. Things are being done through your arm by catheters, and you don't have to open the chest. You can do all these things with a minimal approach. I train these residents every day, and I tell them every day, become a robotic surgeon. Robotic surgery is the future, but it's the present. And if you can't do robotics, you cannot do this business much longer. Pediatric surgery has not yet gotten into it because the miniaturization of the equipment is as such that you can use it, but it will come. It will come. Robotics will be the future for all of surgery. Insofar as what I do everything from a minimally invasive perspective. I use the laparoscope for almost everything.
Really? And just to add on to what you said, cerebral aneurysms. People are always concerned about having their head opened up to clip an aneurysm. Very, very few get done that way. It's all being done through arteries that go in there and they clog it up and they clip it off internally. So there's no scar.
It's
post-operative, post-procedure recovery is very, very short, and patients do so much better.
So if you go a step further and you think about medicine as a whole, the three greatest breakthroughs in the history of medicine was the use of soap and water, Babylon, 1500 BC, 1928, the discovery of penicillin, and then in 1994, the genome. So all of a sudden, medicine is becoming smarter and more sophisticated with greater breakthroughs. So all the young guys coming up right now, the guys in their 30s and 40s, this is a brilliant time to be a doctor because we are understanding cancers, how to deal with cells. Even, for instance, you see port wine stains on kids or any of the hemangiomas. Now, because of the genome and our understanding of the genetics of these things, we can fix these things without radical surgery. So every day we become more minimalist and we become better.
So tell me about where you do surgery. And what hospitals do you go to?
Well, I'm the chief of pediatric surgery at Brooklyn Hospital, and I'm the chief of pediatric surgery here under the Mount Sinai umbrella. So at Rumsey, so I'm by borough. I'm Brooklyn and Staten Island, but my practice is pretty much the same at both places. It's very busy.
And and we talked about the kinds of routine, the surgeries you say. Tell us about the traumas and as a pediatric surgeon, you encompass so much more than sometimes other surgeons because when you're taking care of a child, I think you once said to me, you take care of everything except brain surgery.
That's right. We do everything. And because of that, we're able to handle the trauma cases much more, I think, expeditiously than most. I also did Iraq. So I ran a combat hospital. So I have a sort of feeling for the trauma patients and an understanding that you have to have. But again, as you always say, it's a team. And the team at Rumsey, for instance, because they're a level one, the trauma care, especially by the adult guys who oversee it, is truly phenomenal. These guys are as good as you can get. If I got hurt on Staten Island, I'd want to be there in a heartbeat at Rumsey.
And we've had conversations, and part of the reason I had you here tonight is not just to talk about pediatric surgery. I'm thrilled that, and we do have a wonderful unit at Rumsey. You're a wonderful pediatric surgeon, the pre-op anesthesia people, but also about your opinions about medicine. So sometimes this is an interesting program that we talk about specific medical topics, and we've spoken about some of these things before. But I think you have such an enlightened view of where medicine is going that I love our audience. Sometimes it's hard for me as the host to go and basically talk to our audience, my audience, I'll say, and say, here's our opinion about why it's so difficult to get prior authorizations, why it's so difficult to deal with insurance companies. And again, some of the times we've spoken at length in the hospital, and some of your opinions, I think, are just so relevant that, and I'd love you to have this forum to talk to me and to our audience about what's going on in the world.
Well, medicine for us is never been a job. It's a joy. And there isn't a day, I've been doing this now since 1995 as a pediatric surgeon, and there isn't a day I don't wake up, I thank God I do this. And so when you look at it, when you love what you're doing, and I think most of the people who do medicine have that sense of nobility, that they're going to do good for somebody. It's the one space in the world where you actually do a lot of good for people without any agenda. You're not trying to get them to do this or do that. You're just there to alleviate their pain and their suffering. So all of us who go into this, and I see it in the medical students that we have, and the residents, the nobility is still there. And I think medicine gets better every day, just as America gets better every day. The more diverse genetics, the more people you have from all over the world bringing their expertise, we just become a better country. And the concept of e pluribus unum, out of many one, we in medicine, I think, inculcate that in our everyday life. It's very special. And I'm happy to be a part of it every day.
Mm-hmm. Tell us about the people that you work with. And again, sometimes we talk about the nurses and we talked about the other colleagues and anesthesiologists, but I'm actually going to talk about it at a different level.
But
tell me, and let me finish this website. The people say at Richmond University where we work with, everybody has mentors. And I became a neurologist because of one wonderful doctor. His name was Ramon Valderrama, a super doctor at Downstate, and he trained at Columbia, and I tried to emulate him my whole life. One of the best doctors I know. I know both of us, emulate like a general like Peter Carpenito at our hospital. So maybe just say a few words about mentorship and being able, as a more senior person, again, I hate to say more senior about us, but the idea is it didn't just come out, and the idea of being able to have medical students, residents, younger doctors, even faculty members who haven't been out as long as us, be able to impart to them some of those things, and maybe even talk about Dr. Carpenito's leadership at the hospital, and sort of see how it all comes together. Everybody, and I always think about this with our viewers, when you walk into the hospital, you sort of don't know how everyone is one unit. You sort of think about it as, well, you're in the emergency room, there's an isolated doctor there. You're on the medical floor, there's another doctor there. Or you go to someone's office, you see one doctor there. But when someone mentions the name of a physician, or even tells me about a physician who's in Manhattan, and I train with them, I know them. I'm the president of the New York State Neurological Society.
Wow.
So you look at it, there are 2,000 neurologists that I'm involved with. Yes, I know most of them by name and what they do, and try to put that all together. So in a sense, give us a little bit of an idea about the people you work with and mentor.
So every night, 2 o'clock, 3 o'clock in the morning, or in the mornings when I'm actually washing my hands and about to do a case, I say a prayer to a bunch of these people who trained me. And, in this business, remember, this is a tough business too. You don't always get good outcomes. Young people can die, and it can break your heart. And you've got to have people to whom you can go and actually bare your soul. And a guy like Peter Carpenito, who was here for 39 years and has recently retired, was that one sort of person. He was like a parish priest or your rabbi who you could go to and say, listen, I'm really hurting. And he understood viscerally what we do, as you do, because we're in the trenches every day taking care of those who are sick. And a guy like that had an incredible impact on almost everybody in our hospital. For me, for training, I trained at Harvard with Tony Monaco, who was the most famous transplant surgeon really in the world for a long time. And he was just a very kind man. So when you find somebody who is both kind and competent, those are the people you want to latch onto, because they're the ones who can take you to the heights. There's no other way to get there in this business unless you're kind and competent. Otherwise, you'll be found out.
Absolutely. So let's get back to your specialty a little bit. So pediatric surgery. So first of all, why'd you go into pediatric surgery? You've talked about all the things that you've done. You were in Iraq. You were doing all this trauma surgery.
So do I have to tell you?
You have to tell me the whole story.
Do I have to tell you the truth?
And I'm going to ask you then I'm going to ask you about some of your most interesting cases.
Okay, so I'm going to give you full disclosure. When I was a second-year medical student, and this is for your audience, so I'm an honest man. When I could tell you the reason I went into pediatric surgery was that I felt that the kids are victims, and that we all ask for our diseases, that we smoke or we drink or we drive too fast or we have too much stress. All those things are true. I subscribe to that. But when I was a second-year medical student, there was a girl I was crazy about. She chose pediatric surgery as a clinical rotation, so I did. So I walked into the room where they were doing pediatric surgery in hopes of finding this Maura Kennedy was her name, and they were doing a pyloric stenosis. They were doing a baby operation.
Tell us what pyloric stenosis
Pyloric stenosis is a obstruction of the stomach from too much muscle, and in order to get the babies to eat, you have to fix it. So they were doing the operation in room 4 at New England Medical Center, and 20 years later, I was the chairman, the surgeon-in-chief of that hospital, doing that exact same operation. But I went into pediatric surgery because there's a beauty to the finesse of the surgery. You have to be gentle with the tissues, you have to know your anatomy, and you do good for somebody who's going to live an entire lifetime. It's an incredible gratification to be able to take care of somebody's babies. The other thing that's important to me is that, my mother was an immigrant from Ireland, and she used to tell us all the time, the only people, nobody will ever love you like a mother. And, if you had an Irish or a Jewish mother, you'll understand that your readers or your audience will understand this. Nobody has a greater impact on you than your mother. And my mother was a big proponent of being kind to those in need. And I think when you do pediatrics or pediatric surgery, those in need are the people that are at the forefront of your life. So that's one of the biggest reasons that I went into and love pediatric surgery.
So tell me, you've taught me, and many of the pediatricians have said this. If you think about some of the artwork of the 15 and 1600s, they depict children as little adults. Similar faces. It was very strange-looking paintings if you think about it, because they were babies around then too, obviously. So tell me, you've taught me, and they've taught me that the kids in the pediatric population, even neonates particularly, are not little adults. So how do you put that into context when you examine a patient, when you're talking to the family, and in the surgical realm, what do you have to do differently?
So the most important principle of all is to remember they're made out of water. You and I, as you get older, your audience will know this, your joints hurt a little bit, you don't move as quickly because the water is out of your cartilage. Water is out of your body. We're about 60% water now. The babies are 90% water. So your exam and your understanding of the physiology is predicated on an understanding that water is the key to these babies. So if you have to resuscitate a baby, or you have to understand their fluid and electrolytes, you have to keep it in context that the babies are far more water bound than you are. And adults, you can get away with a lot of things insofar as the diligence that you take care of them with. But with a kid, you've got to be exact and you've got to be precise, because each milliliter counts. How much sodium you get counts. So I think the fundamental thing people have to understand is the babies and the children are made out of water.
Tell us about some interesting cases that you've had, and maybe even I'll go a little bit, 2 steps with the question. How did COVID affect you, the practice, and now that we're post-COVID, to a large extent, the pandemic itself, and again during the pandemic, think about the 2 years at the hospital, how things were difficult and gowning up, and give us a little insight into that with regard to surgery and with regard to pediatric surgery.
Well, as far as I was concerned, I mean, I live in Brooklyn Heights, so driving over here there was nobody on the road. So I made house calls like the old guys used. Patients did not want to come to the hospital. They were scared to death to come to the hospital. So I would either examine them in their car in the parking lot, or I would drive. So I know every neighborhood in Staten Island now because I drove everywhere to see these kids. I'd go there, I'd take out packings, I'd do wound, I did everything. So that was a big change, and it was very insightful for me because all the old timers in the old days used to make house calls, and we never do it anymore. So I did it with a car. I drove around. So that was how COVID affected me. COVID also affected me by appreciating the history of medicine insofar as this is concerned. Anti-tubercular drugs were not out until 1967. All the nurses like my mother and all the doctors like my father took care of a bunch of tuberculosis patients in the 50s, in the 60s, without any qualm or worry. They just took care of them. And we never had that sort of fear. But all of a sudden COVID comes along and you realize the abject fear, it's in you. You still do your job. You come into the hospital, you mask up, but it was scary. And I don't think there's any, I've been to war and I was more scared walking around the ICU than I ever was in a war because it's an invisible enemy. And Dr. Carpenito asked us for volunteers, and we all volunteered. And I did 3 nights a month in the ICU, and we intubated the patients. Dr. Bonenberger, the head of pediatric anesthesia, he spent countless days and nights taking care of those patients, and we didn't have any vaccinations. So it opened up my eyes to the world that the people lived in before. So that's how COVID really affected me, and it scared me.
Absolutely, scared all of us.
Yeah.
And again, patients were coming in who were sick, who had, in my field, strokes and really had to be taken care of. People were having seizures, and they had to be seen.
Right.
And we gowned up.
We did our job.
We pretended to gown up as best we thought we could. And then there'd always be one person who would come in with this spacesuit, whoever they found it from. And we looked at them and they said, it was a little bit difficult for us all to get in and out of the spacesuit, but we put these masks on and we went in and we saw these patients and we saw these people, and not just patients, these were members of our community, people that we cared about, and we went around and around and we did it. And I'll never forget coming home and taking off my clothes 2 and 3 times a day because I was afraid to bring the clothes into the house, even, that anybody in my house should get sick.
But again, it speaks to the nobility of people who do medicine. We took an oath. And by God, we fulfilled that oath. And as scared as we were, we did it. And I think it's very insightful for me to even think about. But if you talk about interesting cases, and I want to bring this up a little bit. Well, I had a kid just 3 weeks ago now. 4 13, 14-year-old boys were hassling a homeless guy. And the poor homeless guy, whoever he may be, was getting pelted with tomatoes by these kids. Now, teenage boys can be very silly and very stupid and not know better, but they're throwing tomatoes at this guy. He breaks a bottle and he shoves it in a kid's face, and he opens the kid's face where the nose and the mouth were completely open. It was like a book being opened. He came into the emergency room, and within 7 or 8 minutes, we had him in the operating room, and we put his face back together. It was like a jigsaw puzzle. And of course, I was there, so I just took them and I did them. And later on, it's kind of like how life is. Somebody criticized me because I didn't ask for the oral maxillofacial team to come in and do the case. But nonetheless, those are the types of things that gives you insight. You sit with the parents afterwards who were very angry at the boy who we operate on but also feeling very sorry for him. But 13 or 14-year-old boys will do things that'll you'll just shake your head and go, I can't believe they did that. And then when there's ramifications of it, you learn a huge lesson. And I think the nurses were saying, well, he had it coming. But, not really, because 13 or 14-year-old kids don't know any better sometimes.
Yeah, no, there's always these difficult cases. And, the tragedies happen, and again, behavior and how we interact with each other is just so important. I mean, I'm not going to even go into that kind of topic. So where do you see pediatric surgery going? You mentioned robotics.
Yeah, robotics is going to. I went to a conference last May where the miniatures. Right now, if you do robotic surgery, you have to put in 8mm ports, which are pretty good sized ports. They're far too large, but they're miniaturizing them down to 2 and 3. The minute that the equipment is 2 and 3 millimeters in size, everything will be done robotically. I would argue that within 5 years, everything will be done robotically.
Do you think AI has a place in pediatrics and pediatric surgery?
Huge.
In what way? Tell everyone.
I think when a kid comes into the emergency room, say a kid comes in with a fever, and they're going to work this kid up. The differential is, pages long. AI can pick it up in moments. It's unbelievable what it's going to be able to do, and it's only going to get better. Everybody's fearful of it, but I think to myself, my Lord, it's going to make everything easier. Although the converse could be true. We thought that cell phones were going to make our lives easier. They cause nothing but anxiety. If you can't find your iPhone, you're a bit crazed. So who knows how these things break ultimately.
I'll tell you my opinion about it. It falls into the idea about virtual medicine. Virtual medicine is very difficult for me. I just don't enjoy it. I don't mind talking to someone on the phone if they need a prescription or for that, but the idea of examining a person over the phone, especially as a neurologist, I can't take my little reflex hammer out.
That's right.
I can't look in their eyes in certain ways. But there was a colleague of mine who said that the biggest difference is the sense of smell. And I looked at him, what do you mean? He said, when you walk into a room when someone who is sick, there's a certain smell.
Absolutely.
And that the ability to sense that or know that or use that sense, whether it's AI or whether you're doing a virtual exam, really does differentiate. And again, doing this for a lot of years, I've been in practice for close to 30 years now. The idea of knowing what people have by actually looking at them, looking at different parts of them that I can't see virtually, really does make a huge difference. And I think that's where the medical students, sometimes you walk into a room and just by a whiff you could tell 5 or 6 facts that blows the medical student's mind.
That's right.
They think somehow you're like a mentalist being able to come up with these things.
That's right.
But that's really what separates. So tell us about what you think.
Well, I think
about
AI then it'll be an adjunct. It'll never replace those sorts of things where you pick up things. We interview all the residents now virtually, which I think is a terrible mistake because I want the kid to come in and I want to see his body language. I want to see how he responds. It's very hard for me to interview somebody virtually. So maybe it's because of our age. The younger guys, maybe they're adept at it, but I'm not. I need to talk to the guy. I need to get a feel for him viscerally. And maybe a smell of them, see what kind of a person he is.
That's good. I want to say thank you, Brian. This was a very quick half hour, as it always is. You've got some wonderful opinions. And I think just the idea of you bringing pediatric surgery to Richmond University Medical Center, all the hospitals on Staten Island, whoever is doing pediatrics surgery, that the ability that people on Staten Island can have this technology, and they don't have to go to Manhattan or Brooklyn or always leave the island if there's, God forbid, an emergency, really transforms our community into really a cutting-edge medical community. And that's why when I came out here from Columbia, Manhattan, years and years ago, the idea of being able to bring the best and the brightest people out with us to do this and help our wonderful community is really something that's been accomplished over the last few years. So with that, I want to say thank you, and thank you to a wonderful guest.
I want to add
and have a wonderful evening, everyone.